very much for inviting me. Is the sound clear?
Yes, sir.
Okay. I'd also like to thank Professor Lindsay because for his wonderful talk. I really agree very much with all the biological reconstructions that he has mentioned. And if it was my choice, I would have switched presentations and presented the biologic reconstruction instead of the endoprosthetic. But I'll try to give my experience regarding the endoprosthetic reconstruction. We're fortunate that we have the availability to do both. So we choose between them without any bias whenever we're going to do reconstruction following resection of malignant bone tumors. Okay, so as we all know, limb salvage is composed of two pillars. We have to resect the tumor with a wide margin and then reconstruct the resultant defect with a method of reconstruction. There are a variety of reconstructive options, starting from autogenous grafts, allografts, prothesis, recycling, combination, bone transport, miscellaneous, rotation plasty, a lot of reconstructive options that we can use to reconstruct the bone defect that results following resection of bone tumors. Ideally, the reconstructive option should be similar in size and shape and strength and durability as the resected bone. But unfortunately, this is not possible. It might be possible for intercalary defects, defects that don't include joints, because whenever you reconstruct these with a vascularized graft, you'll actually resemble the original bone, and you can match all the things that we wish for. But whenever resection includes a joint and you have an osteoarticular defect, then no reconstructive option will actually mimic the original bone. So we want something that's similar in size and shape and strength and durability and function. We can't achieve all this with a single reconstructive option. We have to compromise. Like Professor Lindsay said, biological reconstruction, they are known for their durability. Once the graft unites and hypertrophies, then you have it for life. But if you have an osteoarticular defect and you use a vascularized graft, you lose the function. You wouldn't have a motion. If you use an allograft, it eventually disintegrates and you have the complications of an allograft. So if you use a prothesis, on the other hand, you have a beautiful function in the beginning, but eventually prothesis fail and then you have to do revisions and maybe resort to a biological reconstruction after that. So there always has to be a compromise. So how do we compromise? There are factors that influence our choice for the reconstructive option. So not every patient is the same as the other. The main factors that influence our choice when we're choosing a reconstructive option are the age of the patient, the size of the defect, the site of the bony defect, and the available muscles after resection, if he's going to take adjuvant chemo radiotherapy, the sex of the patient, occupation, what he does, intelligence. So what do we mean by these things? For example, if we take the available muscles after resection, if you have an osteosarcoma of the distal femur and it's so huge that you're going to resect the whole quadriceps and you're left with no muscles, there is no point of doing a mobile reconstruction. The patient wouldn't be able to use it. It's better to do a fusion instead of a mobile reconstruction. If you're going to look at the patient himself, if a patient is a hand worker and he uses his hand extensively, for example, a farmer that uses an axe all the time, you can't reconstruct him with a prosthesis that's going to fail in no time. You'd better do a shoulder fusion, for example, to achieve a better function. So these are a lot of factors that influence our choice when we're choosing a reconstructive option. So if we're looking at the endoprothesis, which is the main topic of my presentation, we prefer the age to be more of a skeletally mature. We can use it for proximal femur, distal femur defects, proximal tibia, proximal humerus, distal humerus, even pelvic resection. But we'll be very hesitant to use it, for example, for distal tibial defects or distal radius defects. The reputation of prothesis in these sites is very poor. Also the size of the defect, you have to have enough space after resection for the stem to be inserted. Otherwise, you'd need a total bone replacement. You need muscles to move the prothesis. For example, if you have a patient with a proximal humeral defect with no deltoid and no axillary nerve, what's the use of putting a prothesis? It wouldn't function enough. You'd rather put a vascularized fibula with shoulder fusion, you'll achieve a better function, and so on. So if we focus on the endoprothesis, the history starts a very long time ago, but it went through a lot of evolution until the form that we have today. In the 1930s, they used to have ivory implants. Then in the 40s, they discovered cobalt chromium alloy called Vitalium, which they found that it was very biocompatible. And this is when Austin Moore started his prothesis. And surprisingly, Austin Moore, when he used his Austin Moore prothesis, it was for a tumor in the proximal femur. He replaced the giant cell tumor of the head with his Austin Moore prothesis. And then there were acrylic protheses, modular segment, custom-made protheses by Markov, until the 80s when the cornerstone became very systematic to do modular endoprothesis until the form that we have today. This is an example of a Vitalium prothesis, ivory prothesis, stainless steel prothesis, and there are several types. We started with custom-made protheses. Now they're modular, easy to use, and we have the expandable for children. The material of the endoprothesis also changed over time. So we're going to discuss these issues. Material started with the stainless steel, cobalt, chromium, molybdenum, and now the standard is titanium alloy, which is the best. It has the equal strength to the stainless steel and cobalt chrome, but half the weight. Wider stems are always better. We'd rather use stems more than 12 millimeters. We'd rather use stems which are not less than 12 centimeters. And if we're going to do a cementless prothesis, we don't prefer longer stems. Fixation could be either cemented with a third-generation cementing technique or cementless. There is always a debate which would last longer, even for modular prothesis. So long that you do a proper technique, both will have equal outcomes. Cementless stems could be hydroxyapatite coated or porous coated. And the concept of extracortical bone bridging is always useful. You have a porous coated or hydroxyapatite coat around the stem, and you can see how the bone ingrowth covers the collar, which protects the stem, whether cemented or cementless. Recently, a new technique for prothesis called the compressed system, which aims at improving bone remodeling. This compressed system uses a compressed spring, and it, by time, whenever the patient loads it, you don't have stress shielding. You have bone remodeling around the collar. It's not that popular, but it's one of the recent trends that has been going on. The modules of the prothesis are usually more tapered. The hinge, we started with a simple hinge, but now a rotating hinge is the standard, which decreases the incidence of loosening and breakage. Now I'm going to show some of the experience that we have in Cairo University regarding different sites in the body following tumor resection. So we start with the humerus. This is the algorithm we have to choose for an endoprothesis. We have to have major nerves. We never do it for intercalary defects. For the proximal humerus, we prefer older individual. You have to have a deltoid and an axillary to use the prothesis. So this is an example of an osteosarcoma of the proximal humerus with an intact deltoid, reconstruction with a modular prosthesis. Sometimes we use a Gore-Tex graft or a Trivera tube to attach the soft tissue muscles to the prosthesis, and at the same time prevent its upward migration, which gives a better function. We use an abduction brace at the beginning to maintain the soft tissue intact and length. This is another example of an osteosarcoma of the proximal humerus and reconstructed with a cemented proximal humeral prosthesis. For distal humeral defects, this is an example of a Ewing sarcoma of the distal humerus. After chemotherapy, we see the soft tissue mass almost disappeared, resected and reconstructed with a modular cemented prosthesis. Usually, the distal humeral prosthesis, they don't give you the full range of motion of the elbow. You have a limited range, not full extension, not full flexion, but you have a pronation and supination. For femoral reconstruction, this is the algorithm that we use. Proximal femoral resection for a Ewing sarcoma, reconstruction with a modular prosthesis, which could be on a bipolar or a total hip replacement. Recently, we published a study comparing both. We found that both would give equal longevity and durability. It's not the total hip would do better than the bipolar. Both would give equal results. This is the patient that was referred to us because they thought he had a pathological fracture due to metastasis. So they did the DHS. It ultimately turned out to be an osteosarcoma. He received chemotherapy, and then we did a wide resection of the proximal femur with the surrounding muscles and reconstructed with a modular proximal prosthesis. This was an old case using a COTS prosthesis. Metastasis following a bipolar that was done, eroded the proximal femur and reconstructed with a modular proximal femoral endoprothesis. Sometimes we use a combination. This is the chondrosarcoma of the proximal femur, and we use an alloprothesis to reconstruct the proximal femur. The allograft is fixed with a bypassed with a long bipolar stem with an anti-rotation plate. For distal femoral reconstruction, this is the algorithm that we use, an example of a parosteal osteosarcoma preserving the whole quadriceps muscle, resected and reconstructed with a modular prosthesis. You have a good extension, good flexion, good gait. This is what the modular prosthesis offer, a good function, but a less longevity than the biological reconstructions. Another example of an osteosarcoma with a skip lesion in the femoral shaft, resected and reconstructed with modular endoprothesis. This was one of the older designs, the COTS prosthesis, which is cementless with a side plate for fixation. For the tibia, proximal tibial osteosarcoma, resected, reconstructed with a modular prosthesis, but for the tibia, we have to reconstruct the patellar tendon as well. So this is an example of a tibial resection. In this case, we reconstructed using both the medial and the lateral gastroc flaps. We usually use only the medial gastroc for reconstruction of the patellar tendon. Sometimes we need the TH graft, often we don't. This is an example of an osteosarcoma that was mismanaged as a benign bone tumor, and a cement was inserted inside. It was resected later on with a wide margin and reconstructed with a modular prosthesis. If you do a proper gastric reconstruction and pulled the patella down, reconstructed the patellar tendon. Usually you have a good range of motion with good extension, but often you have some extensor lag. Complications of endoprothesis are much more common than the ordinary prosthesis. And this is for a reason. Patients are usually younger. It's not like osteoarthritic patients who are old. These are young, enthusiastic, more active patients. They want to walk and run and play sports. So you have also more complications. Also, these patients are immunocompromised. They are very liable to develop infection. They're very liable to have nutritional deficiencies and healing problems. So that's why complications of endoprothesis are more. Operations are usually longer, and large bone defects and soft tissue deficiencies. Complications could be intraoperative or postoperative. Postoperative could be early and late. It's intraoperative complications you can have during insertion of the prosthesis. They could fracture the bone, malalignment, shortening, instability, dislocation. Early postoperative could be skin problems, infection, joint instability, malalignment, neuropraxia. And late, the worst is infection, loosening, and breakage. Wound slough is less than 10%. You have to be careful with the flaps that you develop. Early infection occurs in 10% of patients, mainly in the proximal tibia and the pelvis. Joint instability occurs more in the proximal humerus and the proximal femur. It's caused by the major soft tissue resection. You have to adequately align, use tapes, mesh, etc., to reduce this problem. Joint stiffness, less than 5% of patients. It's due to improper physiotherapy, delayed physiotherapy. So you have to deal with this as well. Delayed infection occurs in 10 to 20% of patients. Endoprothesis, they result in a biofilm. And the biofilm makes the prosthesis very resistant to treatment. And it's very rare that we can solve the problem of endoprothesis with just debridement or antibiotics. In almost 90% of cases, we usually have to do two-stage revision, and we have to inform the patient that in 50% of cases of infection that it might end in amputation or conversion into a biologic reconstruction. This is an example of an infected proximal femoral prosthesis, cement spacer, and then reconstructed with acetabular reconstruction. Loosening is another major complication. It occurs in 10 to 30% at 5 years. Like 1/3 of the patients with modular endoprothesis usually would require revision at 5 years. So it could be due to an improper technique, but often it's just a matter of a time-related event. Whenever you have revision, sometimes you need to do larger resection with less bone stock with every time you do your revision. This is an example of a loose prosthesis, and it ultimately ended that we had to resort to a total femoral replacement after several revisions for the loose prosthesis. Stress shielding is another complication. You can see how the stress shielding with the adequate fixation of the stem, and it causes this stress shielding. So sometimes you have to add an extra block to the prosthesis to avoid this, to solve this complication. This is another example of stress shielding. Usually these are not symptomatic, but eventually they'll cause a problem and they'll cause fracture of the bone. Breakage of the prosthesis is another complication. It happens more with smaller diameters. This is an example of a broken stem that needs revision. Prosthesis has to change. This is an example. or it could disentangle from the hinge itself, and very often you get breakage of the bushings of itself. This is an example of a broken prosthesis as well. Periprosthetic fracture is also a complication, and you can always resort to either cable plates or even regular plates to solve this issue. Dislocation and subluxation happens in the proximal femur and proximal humerus. The humerus sometimes migrates proximally, sometimes it migrates downwards, depends on the soft tissue envelope. This is subluxated total femur. It was an expandable prosthesis, and with lengthening, it subluxated proximally. And we had to reconstruct it, shorten the prosthesis, and do a acetabular reconstruction to solve this issue. So what's the outcome? How long do these prostheses last? And are they able to make the patient resume his previous functional activity or not? Well, to answer the first question, prosthetic replacement, the global 5-year survivorship is around 72%. But it differs from one location to the other, whereas humeral prostheses, they could last for a very long time. This is more than the femur, and this is more than the tibia. But however, although the prosthetic survivorship is around 70%, but the limb survivorship is around 90%, because not every prosthesis that we have to change would actually jeopardize the limb survivorship. The limb survivorship is more than 90% when used in endoprothesis. The average functional outcome also differs. Femoral reconstructions are better than tibial, and tibial are better than the humerus. Humeral reconstructions are usually, they act like spacers more than an actual prosthesis. Finally, I'd like to end my talk with just a brief note on expandable prostheses. These prostheses we use in children. There are different types. Whether the expandable prosthesis, there is the types which we expand by invasive techniques, or semi-invasive techniques, or non-invasive techniques. This is an example of an osteosarcoma distal femur, which was resected in a 9-year-old boy and inserted an invasive, semi-invasive modular prosthesis. You can see here that the expandable prosthesis, the tibia has a very smooth stem so as not to disrupt the proximal tibial physis. And this is the area where we're going to expand the endoprothesis. And we expand it using a screwdriver. We make a small incision, and then using the screwdriver, you can expand the prosthesis. So whenever there is 2 or 3 centimeters leg length discrepancy, we use it to expand it in this technique. We can't expand much so as not to cause flexion deformities of the knee and cause contractures, but the patient is exposed to several sessions of lengthening all through his life. There are disadvantages for the invasive and semi-invasive techniques. There is higher risk of infection with every procedure that you do. Increase in length is staged and cannot be done frequently, and it could be associated with deformities. The other more sophisticated technique is to use non-invasive techniques, like this patient with an osteosarcoma of the distal femur, which was resected, and a non-invasive technique, a non-invasive tumor endoprothesis, expandable prosthesis was done. This is the prosthesis, and this is the motor that goes inside the prosthesis. And from the motor, a cable comes out, and the cable ends with a button that is inserted in the subcutaneous location. And this is the device that we expand the prosthesis with. And this is the stethoscope that we use just to make sure that the motor is working. So here is the prosthesis, and this is the cable, and this is located subcutaneously. So, and whenever you use the device, you put it on the button, and the patient can actually do his lengthening by himself. And this is how we do it. The patient, we teach him how to do it. You put the device, and then this button, you take it and put it so whenever you press the button, you activate the motor. You activate the motor, so it gives certain pulses and it increases the length of the prosthesis by a couple of millimeters. There is another type of non-invasive prosthesis, which is called the Phoenix prosthesis, and it's done through an electromagnetic field. There is a compressed spring here, but the patient has to come to the hospital every time he wants to do lengthening. You get the device, and then you get him under fluoroscopy, and you can do the lengthening. Okay, this is how it's lengthened. So these are the expandable prostheses. It looks nice and sophisticated, but it's also associated with a lot of disadvantages. It's not a permanent procedure. Once the child grows, he has to change it into a permanent procedure. There are high incidence of breakage for these. They're expensive. And they have, in addition, the complication of the regular prosthesis. The future of expandable prosthesis is what Professor Lindsay was saying, is the fit bone. It's that you lengthen the prosthesis, but not by increasing the length of the prosthesis, but by increasing the bone stock. So instead of the stem coming out of the prosthesis, you have the fit bone or the lengthening device. And then you can lengthen the bone with maintaining the same resection length. Thank you very much.
Thank you so much, Professor Walid Ebeid, for this very interesting talk. Thank you so much, sir. Any questions to Professor Walid? Dr. عمرو معانا؟
تمام يا فندم مع حضرتك.
Any questions to Professor Walid?
تمام. في دكتور وائل بيقول could you please explain how the compressed system works?
Okay. The compressed system is a very short. Let me get the device. Okay. Okay. The modular prosthesis this is what we see here. This is like any modular prosthesis, but the difference is this part. This is the stem. So inside this area, there is like a spring. And this is how it's fixed. It's fixed with multiple pins, which make it as strong as the longer stems. It gives the same strength as the longer stems. But the spring here, this is the one that's all about. It's the same as the Wolff's law. It's like when you put strain on your femur, it better remodel. But if you don't put any weight on your femur, the stresses won't make the bone remodel. So what the spring does is that it transforms the weight that goes on the femur into it induces bone formation around the collar of the stem bone interface. So كل الفكرة هي السبرينج اللي موجود هنا اللي بيخلي الفورسز اللي نازلة to induce the bone to form more bone that heals to the collar of the stem.
Yes. Professor Walid, I have a question, sir, please.
Yes.
In the expandable prosthesis, after how much time from the operation I start the expansion of the prosthesis? Immediately post-operative or after how much time? And how do I calculate the amount of expansion? According to the growth chart or what's the calculation do you calculate by it, sir?
Okay. There are several issues regarding the expansion. Usually, when we do the original operation, we try to lengthen the patient for 1 centimeter just to gain more length and to get an advantage at the time of the operation. And then we do them regular scanograms to check the leg length discrepancy. We have to know that every time we do the lengthening procedure, especially in the invasive techniques, we can't lengthen more than 2 centimeters. If we lengthen more, we go into problems. So we have to wait until the leg length discrepancy is between 2 and 3 centimeters, and then we do our lengthening procedure. Just to cope with the other side. Sometimes, if the child is young and he didn't go into the growth spurt, this is done at very infrequent intervals. But for children who are going to the growth spurt, sometimes from a year to the other, you find great discrepancies. So you do it more frequent. For the non-invasive techniques, you can lengthen very slowly and very gradual increments with the instructions to the patient. But there is a point I have to say also, that the potential of the expandable proteases for lengthening varies according to the resected specimen. For example, if you resected 10 centimeters and you put an expandable proteases, the maximum lengthening potential is 2 centimeters because there are 2 rods that goes into each other. But if you're resecting, for example, 20 centimeters, then the lengthening potential will be much, much more. So it differs from one to the others. Then you have to adjust exactly how much lengthening you're going to do.
Thank you, sir. I think we have no more questions, sir.
انا عندي سؤال بس
قول يا دكتور عمرو.
حضرتك يا باشا الاوتكم بس بتاع ال 3 دي برينتد امبلانتس يعني او الاندوبروسيس يعني السبيسر العادي سيمنت سبيسر العادي بالنسبه للرينج اوف موشن الاكتيفيتي.
ال 3D printed implants, we haven't used them except for proximal humeral replacement, and their function is the same as the spacer and the regular Prpfessor, but they don't differ in function. The problem with the function of the proximal humeral reconstruction is not because of the reconstructive procedure, but rather because of the deficient muscles that are available and the deficient mechanism of the rotator and the deltoid combined together. The reverse shoulder endoprothesis solved this a little bit and improved the function than the regular prothesis, but still it's not the function that you expect. Patients would get 90 degrees, a maximum of 60 to 90 degrees. They can't do over the shoulder motion, even with the most sophisticated proximal humeral reconstructions. So the 3D implant wouldn't have a better function.
Any questions to Professor Walid?
تمام.
Thank you so much, sir. شرف كبير لنا ان حضرتك معانا النهارده دكتور وليد بيه.
الله يخليك يا دكتور محمد، ده انا شرف ليا انا.
العفو يا فندم، حضرتك شرفتنا ونورتنا والله يا فندم. دايما حضرتك سبورتر لنا كده في الكورس يا فندم.
ده من ذوق حضرتك بقى.
وجود اسم كبير زي سعادتك بيسري الكورس دايما يا معالي الباشا.
كتر خيرك يا بيه.
Thank you so much, sir. Now we will move to the